Hello, and thank you for attending this session. My name is Marcela Torres, and I'm a fellow at the Centers for Disease Control and Prevention, CDC, in the Mozambique Country Office. I'm presenting the study titled Monitoring and Management of Treatment Failure Among People on Antiretroviral Therapy in Mozambique, Lessons Learned to Improve Treatment Effectiveness. This study was co-authored by colleagues at CDC Country Office in Mozambique, the Mozambican Ministry of Health, and ITEC Mozambique. The authors have no conflicts of interest to declare. Mozambique has one of the highest HIV burdens in the world, with a prevalence of 13.2% among adults. By the end of 2019, it was estimated that 1.3 million people living with HIV were receiving antiretroviral therapy. As more people living with HIV access antiretroviral therapy, monitoring treatment effectiveness is crucial to identifying and managing treatment failure and ultimately improving clinical outcomes among our patients. Factors that contribute to treatment failure are drug resistance, drug toxicity, and poor adherence to antiretrovirals. Currently, viral load monitoring is the preferred approach to diagnose treatment failure, defined as 2 consecutive viral load test results over 1,000 copies per milliliter within a 3-month interval with confirmed adherence between measurements. Patients experiencing treatment failure should be switched to another regimen. Per national guidelines, people living with HIV on antiretroviral therapy should obtain a viral load test at 6 months after initiating treatment and once a year thereafter if they have a viral load of less than 1,000 copies per milliliter. However, a regimen switch is recommended for patients with suspected treatment failure, meaning those with 2 consecutive viral load measurements greater than 1,000 copies per milliliter within 3 to 6 months with adherence counseling between tests. The objective of this study was to identify gaps in viral load monitoring and regimen switch to inform improvements in patient management. We use data from Mozambique's National Longitudinal Patient Level Database, MOSART, which contains information on patients on antiretroviral therapy at health facilities with the highest ART patient volume nationally. We selected a cohort of adult patients, defined as 15 years or older, who initiated antiretroviral therapy between January 1st, 2017 and October 1st, 2018, and followed them retrospectively through June 21st, 2019. We reviewed demographic information, date of ART initiation, pharmacy pickups, and viral load test results. We then categorized patients by viral load testing status, that is, whether a patient received a viral load test or not. We also categorized patients who had at least 1 viral load test into 2 groups, less than or equal to 1,000 copies per milliliter or over 1,000 copies, and identified patients with 2 consecutive viral load tests within 6 months with results over 1,000 copies per milliliter. Lastly, we compared the antiretroviral regimens of subsequent drug pickups to identify a switch in regimen. We used RStudio version 3.6.0 to conduct analysis. Results. During the study period, patients were receiving services in all 11 provinces in Mozambique. Of the 492,652 adult patients on antiretroviral therapy, 65% were female. Only 36% had a viral load test during the study period, of which 38% had a viral load test within 8 months of initiation of antiretrovirals. Of all patients with a viral load test, 24% had a viral load result over 1,000 copies per milliliter. Of all patients with a viral load test of greater than 1,000 copies, 28% had 2 viral load tests greater than 1,000 copies within 6 months, potentially making them eligible for regimen switch. However, only 9% of eligible patients had a regimen switch. Limitations. Potential limitations to this study include underestimation of viral load coverage. If patients had a viral load test, but the information was not digitized at the health facility, then this information would have not been reflected in the longitudinal database, causing an underestimation of viral load coverage. Similarly, if patients had a regimen switch, but the type of antiretroviral drug was not digitized at the health facility, we would have not been able to identify a regimen switch, resulting in an underestimation of patients who had a regimen switch. Another limitation is potential overestimation of those meeting the definition of treatment failure, as adherence counseling data was not available. Lastly, there is potential misclassification of regimen switches, as some ART regimens had been recoded as other in the longitudinal database, which prevented us from identifying switches that happen within the same regimen line. Conclusions. In conclusion, viral load testing does not occur at the frequency recommended by the national guidelines. Moreover, the large majority of patients who meet the criteria to be switched to another regimen were not switched. There is an urgent need to increase viral load coverage while improving viral load monitoring to check for therapeutic failure. Some recommendations to improve viral load monitoring are to ensure that the turnaround time between specimen collection and return is as short as possible to increase the identification of patients with treatment failure. Another recommendation is to implement programs that promote timely viral load testing. These are the references that were cited in the background section. I would like to thank the Mozambican Ministry of Health, ITEC Mozambique, the President's Emergency Plan for AIDS Relief for funding, and my colleagues at CDC Mozambique. Thank you.